So this is a very common published equal analgesic chart. This one is out of the American Pain Society guidelines. And how do we look at this? Well, as I mentioned, morphine is considered the more or less the gold standard. Parenteral, again, is any IV, IM, or sub-Q route, and here's the oral route. So very easily then you can see 10 milligrams of parenteral morphine approximately gives the same relief as 30 milligrams of oral morphine. Or 10 of IV morphine and 7.5 of oral hydromorphone gives approximately the same pain relief. You can see then that there are some areas where we don't have complete data. Oxycodone is not available as a parenteral product. Fentanyl, which is one of our more challenging conversions, where we have that available parenterally. We don't have an oral, but we have it in a lot of other different unique drug formulations, transdermal, dermal, transmucosal, transbuccal, which makes those conversions difficult. Methadone, you can see methadone here, meperidine, which we don't use quite as often anymore, and oxymorphone. So that's what a common, or when you look up an equal analgesic chart, that's what most of them look like. Well, where does that data come from? It's actually decades old data, a lot of it. They were single dose studies in acute pain patients. It's really meant to be a very broad guideline. Again, doing the math is the easy part, and figuring out what it means in your particular patient is when your clinical skills come in. So we calculate the dose and we decrease for incomplete cross tolerance. And then based on the clinical status of the patient, and why are we making that conversion? Is it because the pain's not controlled? Is it because we have intolerable side effects? Or the patient's doing great, but now it's time for discharge and we need an oral route? And the important thing is wherever you start the new regimen, the new opioid regimen, you want to reassess your patient frequently and titrate based on response. So again, yes?
I just wanted to mention there is another situation where the patient can no longer swallow pills.
Yes, so that would be very good. That would be a route where now the oral route, which as you heard Skip say, is really our preferred route of administration. There can be several circumstances where the oral route's no longer available. Absolutely. So the studies, as I mentioned, were mainly single-dose studies, usually in acute pain in opioid-naive patients. So now we have more patients on chronic opioid therapy. Those patients were not included in the study, so we're not really quite sure how those equal analgesic dose ratios really work in chronic pain patients. Some of the studies were retrospective, so they were chart review, so patients who came in were placed on one opioid and for whatever reason was rotated to another one, and then what was the end dose of the new regimen and what was the ratio between those two. And then some studies were crossover studies that patients were their own controls and were switched from one opiate to the other. So you can see there is data behind the equal analgesic table. However, it's certainly not pristine in terms of knowing all patient populations, and of course one of the big ones is the chronic pain population or chronic opioid patient. So I've mentioned a couple times this incomplete cross tolerance, and that once we perform an equal analgesic conversion, then we have a dose reduction. So this is because there's such a large interpatient variability in the response to the different opiates. And this could be a matter of the patient themselves, their age, their organ function, what else is going on with the patient, and how well we're doing with their pain control overall. It can depend on why we're making the change and what particular agents are involved. If we're going from morphine to oxycodone, or in the patient case we were going from oxycodone perhaps to morphine, we may do a standard 20–30% decrease in the new opioid regimen and start that way, start that dose, and then reassess the patient and titrate the opiates until we have good pain relief. Something like methadone, which can be a very challenging equal analgesic conversion, that we have a lot of factors to consider. we may only take 10 to 20% of that initial dose and start the patient there. So the incomplete cross-tolerance is also something that isn't a standard for every patient. So some of our challenging conversions are, I already mentioned fentanyl. It doesn't come as an oral preparation, so we have patches, we have transmucosal and transbuccal lozenges that have been shown not to have any relationship to any other opioid. So you really can't use them in an equal analgesic dose conversion factor. Methadone, there's very good literature to that patients that are on a lot of different opiates or higher doses, or the longer a patient's been exposed to opiates, converting to methadone can be very challenging because methadone becomes more potent. And so it's best that someone who's very well equipped with working with those types of patients do those types of equal analgesic conversions. Oxycodone may be a bidirectional. Some of these, and hydromorphone, have shown to have different conversion ratios, whether you're going from oxycodone to morphine or morphine to oxycodone. So maybe now the sequence of how we're switching those opiates may play a factor. So those are some of the challenges. So what we set out to do was, how can we at least get some information and put applications and software in the hands of clinicians to help them with using this concept of equal analgesia in the care of their patients. And it actually started in 1989 with a 5-inch floppy disk that was programmed in mumps, right, with mumps, which I'm not even familiar with. But then we started, about 10 years ago, we started applications for handheld devices. And then it was PDA's, personal digital devices. So how many Palms do you still use? Does anyone have a PDA? No, they've gone by the wayside, right? Everybody has a smartphone. So here's our Palm application that we had, that we launched in 2002. It was a free download, and we've maintained that. Others have asked us why we don't charge for these applications. Our goal is to get good information and tools in the hands of clinicians to improve patient care. So we made it available for both the Palm operating system and the Windows CE version as well. It was a free download, and I'll show you a screenshot in the next slide. Then with looking at more web-based, we took our HOP, or Hopkins Opioid Program, and in 2005 launched a web-based version, which is actually under 2 different URLs, and they're available there. Again, you register, it's available online, and anyone can use it. So this is the PDA version. I think, Skip, you may have the last remaining Palm with still the PDA version on it. But this is what it looked like, and a lot of the same underlying concept is still there, where you add your the patient's current medications, up to 3 different opiates the patient may be on. PME is parenteral morphine equivalence, so this application converts everything to morphine, and then you choose your new regimen and you get a new dose. And I'll explain some of the other features on our web-based.